Today, we are going to talk about what your partner or advocate's role is in the space, your legal rights in the birth space, and we'll go over different strategies and communication tools to help you communicate and advocate effectively during birth. What is advocacy, and what is the role for the partner or the advocate? So the partner's job is to protect the mother's decision-making space. So to help the mom and support them in making the choices that feel right to them. Also to help slow things down when there's time to do so, to make sure that the mother understands what is being recommended, to notice when the mother's preferences are being overridden and to step in, to speak when the mother is deep in labor and isn't able to speak for themselves, to keep the relationship collaborative whenever possible, and to become firmer when collaboration isn't working. Also, the role of the advocate or support person is to keep informed consent intact. Informed consent means that you, as the person giving birth, understand the risks, benefits, and alternatives to all of the options available, and you know that you can say no. So there are two pieces to this. You understand risks, benefits, and alternatives, and you understand that you can say no. This is a really important piece that a lot of moms forget about when they're giving birth, because the medical system is highly flawed. Many providers are seeing many people, and it kind of becomes a little bit routine. We give this recommendation and then we leave, and expect that the recommendations will be followed. Or we're following along algorithms and policies. It's been 3 hours, you get a cervical check. Your water's broken, you get Pitocin, right? So if someone wants to do something different than that, it can feel a little bit jarring. And sometimes providers don't see someone as a person that wants their own preferences to be honored and, that wants that individualized care. Often providers are really just trying to follow, the routines and follow the policies, and may forget to really invite someone to see that they can say no. So let's talk about saying no and that right a little bit more. So in the individualized model of care, which is typically seen with an out-of-hospital midwife, in that model of care, we're considering your preferences, your instincts, your intuition. We're considering the recommendations, what the provider has to say, right? And all of that is part of the decision-making process, and the parent ultimately makes the decision at the end of the day. That is the culture, and that is the model of care and the way that care is approached typically. Every provider is very different, but typically in the midwifery model of care out of hospital, that's what it looks like. But in the obstetric model of care, or the mixed model of care, which means there's a midwife in the hospital, because hospital policies are oriented around liability, convenience, and profit. And hospital policies are, even though they're not law, they are the way that the providers and the nurses have to do things to keep their job. So providers and nurses are limited in what they can offer. They also are seeing many more people and they don't have as much time. And so this can kind of create a culture where someone comes in and the nurse says, we need to give you a cervical exam before we can admit you to care. And the mom maybe says, oh, I don't really want a cervical exam. And the nurse is like, well, I have to do that, and it's kind of confusing for the nurse, this is what we do. And so in an individualized model, we would ask the mom and the mother would say no, and that would be more honored. But it may be that in the obstetric model or the mixed model of care with midwives in the hospital, because we're following those policies, algorithms, and routines, it may feel harder for the mom to remember that they have the right to say no, because they aren't being supported in saying no, and they aren't being reminded that they have that right. So going back to advocacy, your partner or support person can support informed consent in being intact by reminding the mom that they have the right to say no. Let's go over a few examples of this. You'll hear this more in different scenarios as we go on. Oh, one person just asked, you don't have to have a cervical exam to be admitted. No, you don't have to have a cervical exam to be admitted. Let's use this as an example. Let's say that the mom shows up at labor and delivery and is in triage, and the nurse goes through all the questions. What I recommend in this scenario would be for the partner or support person to answer the questions as much as possible. Oh, she ate breakfast. Her water's not broken. She's been contracting for 7 hours. Like kind of give all that information, because they will ask a lot of questions so the mom can focus on laboring. And then when the nurse says, okay, now it's time to get on the bed, we're going to do an exam. It might not be presented as an option. It may be presented as, this is what we have to do next. And it's hard sometimes to feel like, oh, wait, I can decline if someone's saying this is what we have to do next, but you can decline. You can decline anything you don't want. And we'll talk about that more soon. So in that scenario, if the mom doesn't want an exam, the mom might do this. Right? Like maybe she's deep in labor. She might kind of shake her head. She might shrug her face. She might look at the partner like, with wide eyes. She might like get really quiet and shut down. There are many different ways that the nervous system responds to being in a situation where someone doesn't want something to happen, but there's pressure for them to do that in a vulnerable setting. And so if the partner understands how the mother responds or acts when they're feeling uncomfortable, that might help the partner to understand, oh, this is like a situation where I need to step in. Also, sometimes with body language, it's pretty clear. Shaking your head, scrunching your face, like making a sound that you don't want something. And that might be the way, right, that someone is able to communicate, especially if they're really deep in labor, that they don't want something. So if this is happening, then the partner can say, it doesn't look like she wants a cervical exam. So that is to be the voice for the mother. If the mother is like clearly shaking her head, saying no already, or saying no with her body, already expressed beforehand that she didn't really want to do cervical exams or really wanted to limit them. And maybe the mom just says, no, I don't want that. And then the nurse says, oh, well, we have to give it to you. I understand you don't want it. I understand it's uncomfortable, but we really need to do it so we know what's going on with your cervix. We can't admit you to care until we know what's going on with your cervix, right? So if this comes up, partner could then just say, oh, she said no, right? Just decline again. Oh, she said no. And if the nurse continues to push, partner could explore alternative with the nurse or support person. And so that might look like, well, she's been contracting for this many hours. We've been at that 5-1-1 rule, and it seems like it's really intense. So like we believe she's in active labor and we're ready to get care, to be admitted to care. Can we assess if she's in active labor from her pattern? How about we time some contractions? So that's an alternative to doing an exam to see how far along someone is. If you've been following me for a while, you've probably heard my speech several times about how cervical exams are not a good way to assess progress. Sure, like if you want to get a baseline and understand where your cervix is when you are admitted to care, that's totally fine. But at the same time, cervical exams really don't give us much meaningful information as far as like how far along you are or when you're going to have your baby. There was a video that went viral on Instagram maybe last year where a mama of color was refused to be admitted to care because she was 3 centimeters dilated, despite her and her partner saying, we are deep in labor and this is feeling really tense and we want medical care. And they said no and sent her away, and she had her baby 8 minutes later in the car. So this is an example of how cervical exams are not a good way to identify when your baby is coming. Active labor is defined by 6 centimeters of dilation. But this woman was in transition at 3 centimeters dilation. So that doesn't apply to everyone. Cervical exams really don't mean that much. I think they're helpful to assess baby's position because that can give us really meaningful information, but it's definitely not required. So yeah, so in that context, partner can, just to summarize, decline again, speak for the mom, and can also say, let's explore some alternatives. There's also a law, it's called the EMTALA law, E-M-T-A-L-A. EMTALA is a federal law that requires Medicaid participating hospitals with emergency departments to provide appropriate medical screening and treatment and stabilize you if you go in. So that means if you go in and you are pregnant and in labor and you're about to give birth, the way to stabilize you in that medical condition, right, would be to deliver the baby and deliver the placenta. So they can't send you away. If they do send you away, the hospital could face very heavy fines and also potentially challenges with being able to contract with Medicaid in the future. So that's a really big deal for the hospital. So that is a lot to be aware of. Active labor is specifically addressed under EMTALA. So this means if you go to the hospital and someone says, well, we can't admit you unless we perform a cervical exam, and you say, no, I'm not doing an exam, they can't refuse you care right? It would be an EMTALA law violation, and it would also be a violation of informed consent and a violation of your legal right to choice. So let's talk about another law. This is the main law that I want everyone to be aware of, which is your patient rights, the right to informed consent, the right to say no and anything that you don't want. And so federal hospital patient rights regulations recognize a patient's right to be informed about their own health status, to participate in their care, to make informed decisions, and to request or refuse treatment. So these are the main rights that you have that I want everyone to be aware of. A recommendation is a recommendation. A policy is a policy. Recommendation is just your provider's opinion. A policy is just the way we do things around here. Every provider is going to tell you something different. Every hospital is going to have a different policy. You go to one hospital, we do continuous monitoring for everyone all throughout labor, and that's the way we do things, and we do not support intermittent monitoring, even for low-risk moms. Okay, go to the hospital next door. Oh yeah, intermittent monitoring is the way we do things around here for low-risk moms. Oh, what do you know? It's a difference in policy. Policies are not created and framed around the best updated evidence that we have. They're not created and framed from this place of how can we support outcomes for parents, right, and babies. Policies are there to protect convenience, liability, and to protect the hospital. They are made by policymakers who are higher ups in the hospital who have to consider liability and profit. So hospitals make more money when we induce. Hospitals make more money when there are many interventions. So supporting families and having lower interventions births, there's not a lot of incentive to that. And also because of the evidence practice gap, which means it can take sometimes several decades for new research and evidence to make its way into policy, it's very possible that you may come across a policy that is rooted in an outdated recommendation, an outdated way of doing things, or it's oriented around profiting for the hospital to profit and make more money, not really oriented around what is the most evidence-based approach. And every hospital is very, very different. And this is why I like to take my private coaching clients through a provider audit to ask questions and kind of figure out where the evidence practice gap is in that hospital so that we can be more deliberate, making choices that are to support you in reducing the risk of whatever gaps there are. If there's big baby bias, a higher rate of C-sections, or a high rate of episiotomy, if it leads one way or the other, we're going to incorporate evidence-based strategies to reduce those risks in that category, if that makes sense. So understanding your hospital, asking those questions around intervention rates and their approach for things and what their policies are is really helpful so that we can be really informed and deliberate in the way that we approach it. And you can also assess like, oh, is this not the right hospital for me? Because some hospitals are very evidence-based and some are not. So we want to understand that. Actually, I wanted to read the ACOG committee opinion number 664. ACOG is the American College of Obstetricians and Gynecologists. It's important to understand where ACOG stands on these things because many providers will quote ACOG, and they should, follow ACOG guidelines around all the things that they do. And so this is one piece where ACOG is recommending one thing, but providers may, approach birth in a different way. And understanding this contrast, I think, is important. ACOG's refusal of medically recommended treatment during pregnancy reinforces that pregnancy does not eliminate a patient's authority. So they say a decisionally capable pregnant patient has the right to refuse recommended treatment, even when her provider believes that treatment would benefit her or her baby. Done. Okay? You have the right to refuse recommended treatment even if your provider disagrees with you. ACOG opposes forced medical interventions during pregnancy. ACOG also states in its informed consent guidance that a capable adult may refuse treatment during pregnancy, labor, and delivery, including treatment believed necessary for her health, survival, or that of the fetus. So if a provider says to you, I think that you need to have a C-section, does that mean you have to have a C-section? No. If a provider says to you, I think you need continuous IV fluids, I'm worried you're getting dehydrated, does that mean you have to get IV fluids? No. If a provider says, I'm concerned about the fact that you haven't gotten any cervical exams and we really need to see what your progress is, you have to get one now. Do you have to get a cervical exam? No, you don't have to get any medicine. You don't have to undergo any procedure. From something as simple and routine as a cervical exam or IV fluids, or as extreme as a cesarean section, all of that is optional. And I think what scares families is that they go into birth feeling like they're going to have to fight with providers, feeling like they're going to be pressured and recommended things, and they're going to shut down in their nervous system and feel afraid and not know how to navigate those situations. And I think the thing that scares parents the most from what I have seen is the cultural approach to informed consent, which is heavily lacking, right? Where providers will say, this is what you need to do. This is what I recommend, or this is what you have to do, or we have to do this thing, and getting pushback around that instead of being supported with informed consent. We need to have a huge reform in the culture and the way that we value informed consent and approach it. And so that's not your job to solve the problems of the medical system. It's also not your job to go in and be angry and fight with providers. Instead, what I recommend is to go into birth fully understanding your rights. Because if you acknowledge, okay, I have the legal right to do whatever the I want. And also, I have the legal right to refuse anything that I don't want, and that applies for me and my baby. So that means that I'm good. The law's on my side. And so we might face pushback, but if we have the tools and the strategies to work with that, then we're going to be okay. And most of the time, we can really reduce the risk of experiencing harm or pressure or having negative experiences because we're going and recognizing that we are the most powerful people in the room. You chose to give birth in that location, and you are paying them. So they're working for you in a way, if that makes sense. And you can always, go somewhere else if you have the ability to do so. Obviously, there are maternity healthcare deserts in areas where it's hard to access like multiple options. But for most women, around the world, there are options where they can, choose from different providers or different hospitals. And so understanding that you are the most powerful person in the room, and having your partner understand that they are also with you, the most powerful people in the room, that really changes everything. And so advocacy is not about, and now I'm kind of getting into the approach for advocacy, it's not about confidence. A lot of moms say, I just need to build the confidence. But pregnancy is not really the time to build your confidence and do a lot of deep nervous system rewiring work to be able to show up to advocate and push really hard. Instead, what I recommend is, when you're thinking about advocacy, approach it in two different ways. One is to know yourself, know your nervous system. What are the things that make you feel like you're shutting down? What are the ways that you feel if you feel scared or nervous, how do you express that? How do you express without using words? If you don't have words to express, what ways do you do that with your body language? Kind of like we were talking about earlier. So know yourself. And then what I recommend is to be vulnerable. Share with your provider, your doula, your mother-in-law, your partner, all the people who are going to be at your birth. Be vulnerable and share with them, these are my patterns. These are my triggers. These are the things that make me feel like I'm not very safe. Or when I don't feel safe, I'm going to do this. If I'm in a situation where a provider says I have to do something, that's, I think, going to really trigger me. These are the things we can do to help me feel safe. So have a conversation with them about it, but then also have a conversation with your provider. I'm really afraid that someone's going to force me to give birth on my back because I heard these really scary stories. What are the reasons why I would, need to be on my back? What does that look like? Oh, if you recommended that I'm on my back and I declined, what would that look like? I might decline. Really, if you tell me to be on my back and there's not a medical emergency, I'm probably going to decline. Is that going to be okay with you? How can we work together to help me feel safe in that situation? Right? So we're trying to approach it as we're a team, we're a part of a team. Sometimes simply being vulnerable and inviting your provider to be part of your team leads to a super positive experience. Providers often are really good people that want to do their best and want to take good care of you. And they're working in a very flawed and stressful system where they have to worry about a lot of things that you might not even have to think about, like the paperwork and the policies and the, lots of different challenges. For example, I heard a story about some nurses who, in this one hospital, they were told that they have to turn around the room about 5 to 6 minutes faster. I think it was like 117 minutes to 122 minutes. They wanted to bring the 122 minutes of a mom in the room after she gives birth down to 117 minutes because efficiency will make the hospital more money. So they're trying to rush the nurses and rush the parents to get into the postpartum rooms faster after a baby's born. So it's important to understand and have empathy and compassion. Those nurses aren't just here to like take your vitals and support you through birth and take care of you. They're here to serve the hospital and to follow whatever arbitrary, types of practices and like policies, fulfill those for the hospital. And like those poor nurses, like they did not get into nursing school to like help the hospital make more money. They went into nursing school to take care of people and to fulfill their passions. And they also, to work as a nurse, have to follow some of these stupid rules. So we can have compassion and have empathy for the people taking care of us in the birth space, recognizing that they're doing their best in a very flawed system. And at the same time, we don't have to change anything about our approaches. We don't have to like sway or compromise to make things easier for other people. You don't have to do that. Instead, you just have to acknowledge where they are. And so in that way, we're bringing in the empathy and compassion. So I would start by assuming positive intent first. So instead of like, if you're kind of like me, like I've experienced like I've had many negative experiences with medical providers as a woman, and I know many women have. So whenever I go to a provider, I notice in my nervous system, I shut down. Whenever I see a new provider, and I just found a new acupuncturist after going through a few, trying to find the one that I thought could help me. And with each one, I'm kind of just like, here it goes, and I'm kind of like bracing, and I shut down, and I don't feel very open. And I'm just noticing that about myself. And I might even explain, like, I've had these experiences with past providers, and I'm kind of feeling this way. And like, hopefully I can warm up over time. And these are the things I need to feel safe. These are the things I need to feel supported. And I found the right one for me. But I noticed that about myself, So instead of approaching it as like, this person is someone that we're going to have to fight against, and they're going to be really challenging or whatever, I would approach it first by assuming positive intent. Even if the provider comes in and says, hey, I'm Dr. So-and-so, your labor's taking a while, time to give you some Pitocin. It's like, okay, like that was a lot right now. We're just meeting you and you're telling us to get a medication that we don't want. We indicated we don't want on our birth plan. But we're going to start by assuming positive intent. So instead of just going like, oh, this person is like really bad and like we're just going to have a horrible experience with this person, I would say, oh, hi, it's great to meet you. Welcome, to our team. Would you, like as a support person, I would say this, would you be open to like looking through our birth plan really quick and have a conversation? These are our goals. These are our preferences. It would mean so much to us if you could support us in having these be intact. Thanks so much for taking care of us. We're really glad like that you're part of the team, right? Like, so we're approaching it from empathy and compassion. And this person clearly doesn't understand our preferences. They're probably just a really busy provider jumping from room to room. We're just going to take a pause and kind of go over that with them, and then we'll reassess, right? So we're just approaching it from that positive place. Next thing I wanted to say is that you don't have to justify or explain yourself for any decision that you make. So I think where parents go wrong with advocacy is that when a provider says, oh, you need to do this, then we say, well, that's not evidence-based. Continuous monitoring is not evidence-based for low-risk moms. Like that increases my risk for a C-section by 63% and forceps and vacuum by 15%. That's not something that I want to do. So let's say you're in a prenatal appointment and you're sharing a conversation with your provider and you're giving them the birth plan and they're saying, oh, well, we don't do continuous monitoring. Instead of going, well, now I'm going to have to educate this person and taking that upon yourself and going and printing off the evidence-based birth article and bringing it into your next appointment and having your provider read it, don't do that. Instead, just agree to disagree. So you can say, okay, like I understand that that's where you are, and I'm still not going to change my mind. Another thing you could do if you're disagreeing with a provider during a prenatal appointment, in addition to just like being firm in that with that description I just gave, would be to say something like, let's table that. Like I understand that, you guys want to do continuous monitoring. I really feel more safe and comfortable with intermittent monitoring because I want to do everything I can to reduce my risk for a cesarean. That's important to me. So we're being vulnerable. It would really mean a lot to me if you could support me in that. But if this is like kind of a hard thing for us to talk about right now, maybe we'll just talk about it later. Or you could say, this is important for me, but I'm open to discussing it another time. But I'm open if things need to change. So we're just kind of pushing it off. We're not saying it will be this way. We're saying, yeah, I get you. Here's me and my preference. Let's like maybe table this. Let's like reassess another time. Or you could say, if I'm low risk, but if something comes up, I'm open to reevaluate, right? I'm low risk. I want intermittent monitoring. I know it's safe and evidence-based. I'm open to reevaluate. So we're not wanting to have a long drawn out conversation where you're arguing and trying to teach someone. If someone is really so closed off to incorporating evidence-based tools into their practice, chances are one pregnant mom is not going to change their mind, or not going to get them, you're not going to get them to see things your way. They're clearly locked in their ways, and whatever it is that they're doing is benefiting them. And that psychological construct and like wall of like, I'm not willing to support my clients in having safer births because I'm so focused on practicing defensive medicine with continuous monitoring, even though I know it means I'm going to C-section more moms, but it protects my liability to get that continuous tracing, and that makes me feel safer in my nervous system. That person is so rooted in what it is that they want to feel safe in their work that they're not going to change their mind just because one mom was like, wait, that's not evidence-based. They probably already know that and they don't care. And so why change their mind? Instead, we agree to disagree and know that like you're going to make whatever choice you're going to make. And if they have a problem with it, then that's their problem, not yours. So during prenatal appointments, in addition, I also recommend that you bring someone with you to appointments, especially at the end of pregnancy. When you go over the birth plan with your provider, always bring someone to that appointment. When we go over induction or anything out of like the normal vitals and stuff, these things can come up at the end of pregnancy. So when you're and beyond, that's when those conversations can happen. And so it's really important that you're bringing someone, if you can, to those appointments. If you can't, you could have a phone with your partner and put them on the phone on speaker, or with your doula, or with your mother, someone, and have that person be present for those conversations, so that you're not alone having to navigate that, if that makes sense. So I'm going to give you one quick story and then we're going to move on. So I was listening to the Evidence-Based Birth podcast, and there was a mom in the military who was on her own actually at a prenatal appointment, and she just happened to have a lot of confidence. I feel like it's very hard for moms to do this on their own, but she met her provider and was going over her birth plan. And she said she wanted to birth in an upright position, like hands and knees. And the provider read that and said, I don't really support hands and knees. Like, I don't know how to deliver babies in that position. And she was like, you don't know how to deliver babies in hands and knees? And he was like, no, like it's important that you're on your back during pushing. Like you can labor in whatever position you want, but when you're pushing, I need to have you on your back because that's how I know how to deliver the baby. And she said, well, I'm not going to be on my back. And he said, well, you have to. And then she said, well, I'm not going to, she just was like really firm. I understand. And I'm not going to be on my back. I'm going to be in whatever position I choose. And then the provider said, well, I'm just really uncomfortable with that. And then the mom said, well, you're just going to have to be comfortable with that. So this is an example of someone who is just like very, very firm in her choices and also firm in her knowledge of her rights. She knows she has the human right to birth in whatever position she wants. So she's going to exercise that right. And he's just going to have to be comfortable with that. That's an approach that can be harder for some moms to take because it requires a lot of like, well, you're just going to have to deal with that. That can feel a little bit scary for some moms. So that might not be the right approach for you. For you, it might be better to table something and go, okay, well, thanks for sharing your preference with me. Maybe we'll check in about it another time or something like that. And then we're going to like rely on, really create a plan on how we're going to protect that right for you and have your doula or your designated advocate, your support person, be the one to maybe let that doctor know when they come in for delivery, like, hey, she's staying in whatever position that she chooses. Let's go into next the advocacy ladder, and then we're going to go into strategies. So the advocacy ladder matter, this is a 7-step process that partners can use to support them in having conversations and being collaborative in care. You don't have to like memorize each one of these, but I'm kind of teaching this as a framework so you can see the steps. So the first is curiosity. So let's say a provider says, I recommend that you do this thing. Okay, help us understand why. Why? If a partner could go into labor and delivery going, why? That's how the brain is oriented. Why? I'm just going to ask why. Second is collaboration. How can we accomplish both goals? Right? So like mom really wants to labor in whatever position she wants. You guys are having trouble monitoring with the continuous monitor in every position, and you just want to get that continuous tracing. So how can we accomplish both goals? What are some things that we can explore? Do you have wireless monitoring? Can I like hold the monitor on the mom's belly while she's in this kind of funny position for a little bit because she really wants to be here even though the monitor keeps slipping? Like, can I hold it for a bit? Like, can we have a conversation about that? And then preference. So we really prefer this. So share the preference. And then next, share the decision. She is declining this, or she consents to this. But if we're declining, we want to say, well, she's declined this, and then we want to hold the boundary, which is number 5. She's already declined. We declined that. We said no. And then number 6 would be the care requirement. This is the kind of care she requires. So if someone says, well, you have to do this thing, and then partner says, I know, but we declined, or thank you for sharing that, and we declined. We understand and we declined, right? And then they say, but it's policy, but it's really inconvenient for us, right? But. Can say, this is the kind of care we require. I know it makes it harder for you guys. This is the kind of care we require. Number 7 is the escalation. So if they're still really having a hard time with that decision, I think this is rare, but this can happen. And this kind of takes me into obstetric abuse, which is where a provider does something to your body without your consent, or uses coercion or fear mongering or manipulation to try to sway you to do what they want you to do. And this is not okay. And you have legal rights protecting you from this. But unfortunately, it is something that can happen, all around the world. So next is escalation. So then we're going to ask for a charge nurse or a physician attending or a patient advocate. Many hospitals have a patient advocate. So you can say, oh, well, then we're going to talk to a patient advocate. Can you please send one in? Right? Or you can look at your hospital's patient bill of rights. And if on the patient bill of rights, it says you can request a new provider in labor, I think we want to know that before going into labor. So you can say, okay, well, we're going to exercise our right to request a new provider then if you can't respect our decision. Yeah. And so understanding that you can always ask for help is important. If you feel unsafe as a partner and as the mom, if both of you feels unsafe, you could go to the nurse or the charge nurse or a new nurse, and you could say, we really don't feel safe. We're afraid. We're afraid of obstetric abuse. Can you help us? Can we go over our options? This is a thing we don't feel safe around. Can we create a plan with the nurse to have some advocacy support with this provider to help us with whatever it is that we're dealing with right now? Or is there a possibility for us to get a new provider and see if that, helps us feel more safe if this person really isn't respecting our choices? And I know people who have done that, I know this one mom who had this horrible provider who she didn't know, and he was really unsupportive of all of her evidence-based choices. And so they just got a new provider, and it happened to be a midwife, and the midwife came in and was amazing, and they had a great birth, So this is something that's important for you to know if you can do and understand that about your hospital. Let's now talk about strategies. So one strategy is BRAIN. BRAIN goes over basically questions to support you in being collaborative in your care. Every partner should have BRAIN memorized. So learn BRAIN and teach it to your partner and have them practice it with you. B, what are the benefits? R, what are the risks? A, what are the alternatives? I, what does my intuition have to say? And N, what about doing nothing? So if the provider comes in and says, your labor is taking a long time, I think you need Pitocin, we can say, okay, what are the benefits of Pitocin? Well, it can make your labor go faster. Okay, what are the risks? Well, it can cause labor to be more painful. It can cause uterine tachysystole, where your uterus contracts back to back. It can cause oxytocin receptor downregulation, where your uterus kind of is not responsive to oxytocin anymore, and that can increase the risk for hemorrhage or make your uterus not contract anymore. It can potentially lead to fetal distress, and it can make labor more painful and increase the likelihood for pain management. Okay, cool. That took me like a minute to say. If a provider ever says, oh, it's your natural oxytocin, there are no risks. If a provider ever says there are no risks to any intervention, that's not true. So if something like that comes up, you can say, like, I would kind of I play dumb a little bit. Like, you don't have to be like, you're lying to us. Instead I would just say, oh, it's interesting. Thanks for sharing that. When my birth class, like my birth educator said that there were a few risks. I just can't remember them. I know that like there are probably really rare risks that we don't have to worry about that much, but could you just share with me, like, I just want to know all the risks. It would mean a lot to us if we just understood, because we really want to make an informed choice. Would you support us with that? I would just like handle it that way. Alternatives. So could we try the breast pump? Could I get in the shower skin to skin with my partner, release my own oxytocin? Is there a positioning challenge with baby? Can we correct that? So what are the alternatives to speeding up my labor? Intuition, or how do I feel about this thing? Sending them out of the room, that's a tool that I want to get into here in a second, but it's called Clear the Room. So clearing the room is a great way for you to check in with your intuition, because it's hard to say that you don't want something in the presence of someone who wants you to do that thing. The last is nothing. What if we do nothing? Oh, you want me to speed up my labor, but what if I say no? What does that look like? And the provider might say, oh, well, then I'll just check back in with you in an hour or two. Just keep going as you are, okay, cool. So sometimes providers say there's a problem and you need to fix it, even though there actually isn't a problem and it's just their opinion. I know many moms who had a provider who said in labor, I think you're going to need a C-section, kind of worried about this thing. And the mom's like, well, am I healthy? Is this an emergency? And they're like, yeah, you're fine. It's not an emergency, but I think that your baby's just getting too big. You've been in labor for a while. I think we're probably going to need a C-section. And then the mom says no, and then she has a vaginal birth. Many, many times I've heard those stories from my clients, my students, from my in-person classes in town. So just because someone says that there's a problem doesn't mean there is a problem. Brain is important because it helps informed consent be intact, right? You understand risks, benefits, and alternatives, and you understand that you can say no. If your partner ever notices that you feel like, I don't know if I want to do this thing, I'm not sure about it, your body language, right? You can say no, reminding you to say no. That's a really great strategy, to remind you to say no, or that you can say no, that you have that option. Also, whatever, or sure, I guess, or fine, that's not yes. That is, I would say, it's neutral. Like that's not a yes, it's not a no, right? And there's a big difference between saying yes and being compliant and doing something you don't want to do. So if a partner notices you, say, whatever. If they're like, you have to get on your back, it's like, fine, whatever. I just don't want to fight with you guys. That is not yes, I agree to this intervention, which is to put my body in a position that I don't want to do for you, right? That's an intervention. That's not consent. Saying, I understand that I have the right to say no to this. I understand risk benefits of this. And I'm still going to say yes, that is consent. Okay, next let's go into a strategy around a situation where a provider comes in and says something that maybe feels kind of scary and you don't quite understand if you have time or if it's an emergency. So you should say, okay, is this an emergency or can we talk about it? Do we have time to talk about this, or is this something we have to respond to right away? Clarify if there's an emergency. The next strategy I wanted to talk about would be to ask for the least invasive option first. And so if someone says, I think that we need to break your water because your labor is just stalling, and I think that this means the water needs to be broken. Okay, what is the least invasive option we can try first? You're worried that the labor is stalling, right? And the provider will be like, yeah, and if it stalls and we don't fix it, you're going to have a C-section. Okay, yeah, well, we don't want that. But what is the least invasive option that we can try first? And ask about that first. The next strategy would be to ask them to problem solve with you. So you can say, we understand your concern. What options do we have to address that concern while still protecting her preference to do this? And I mentioned this before with the continuous monitoring. So we understand that the baby's heart rate is going down a little bit and you want to do a C-section. What options do we have to address the concern of baby's heart rate going down that also might allow her to have a vaginal birth because that's what she really wants? oh, well, we could do an amnio infusion, which is where we put a tube in the uterus and it puts water into the uterus and creates a cushion around the baby's head. Sometimes that can help the heart rate go up. We could also try putting mom in hands and knees, right? So these are alternatives. So we want to ask about those alternatives in a way that's like we're problem solving together, we're a team, and we're exploring options. The next tool would be, or strategy, would be what would change your recommendation? So what specifically is driving this recommendation? That's something you can ask. What would need to change for you to feel comfortable continuing? And what are you watching for? So we're going to ask for information. And this can be helpful if someone is recommended a cesarean, if they want to do continuous monitoring, if they want to do induction. What would change your recommendation? So if a provider says, you're getting to 40 weeks in a few days, you're close to 41 weeks, I think we should talk about induction because you're going past your due date and the risk for stillbirth increases after your due date. Okay, well, I really don't want an induction. Provider says, well, you really need to have one by 41 weeks. Okay, what would change your recommendation? Is there something that I could do that could change the recommendation or help you feel more comfortable with me being pregnant a little bit longer? Well, my recommendation's the same. I want you to have your baby by 41 weeks, but I would be more comfortable if you really wanted to go over by a few more days or something if you do monitoring. This is what the monitoring looks like. Okay, so we're finding compromise and we're working together. And compromise isn't really the goal ever. The goal is for you to feel safe and confident in your choices. That's the goal. So you don't have to compromise. A lot of moms say I just don't want to fight with a provider and I'm going to just compromise with them about this thing or that thing that I don't want. You don't have to do that. I want you to feel yeah, I feel confident in that. I'll totally come in for monitoring. If it means you're more comfortable with me staying pregnant longer, that feels good for me, right? So I want you to feel good about the choices. Sometimes compromise is a way to do that, but not always. You can also just decline, and that's okay too. So the next strategy would be ask for numbers instead of adjectives. So sometimes providers will say, your blood pressure is really high. Baby isn't tolerating labor. Labor isn't progressing. So instead of being oh, there's a problem, labor isn't going well, right? There's an issue, the blood pressure is really high. The risk for stillbirth dramatically increases, it doubles, right? This kind of language can make it seem scary. This is fear-mongering language, and sometimes providers don't mean to present it this way, but it does come across that way. That's what parents hear, there's something really wrong and they should be afraid. And fear is how we get people to do things that we want them to do. But that's not a great way to approach decision making. We want you to make choices from a place of confidence. So instead, I would ask for the actual information. So if you're the partner or support person and provider comes in labor and says, your blood pressure is getting really high, I'm worried about this thing. You can say, what is her blood pressure? What are the numbers, right? What is the fetal heart rate doing? How long has this been happening? How much cervical change has occurred and over what period? What's the baby's station if we're worried about labor not progressing, right? Ask questions and get information on the specifics instead of just hearing the scary thing that they say. So for example, the risk for stillbirth doubles from 41 weeks to 42. And so you have to have your baby by 41 weeks. Oh, well, it doubles to what? And it doubles, from about, is it 14 or is it 17 per 10,000? I can't quite remember, but it's around there. And it doubles from around there. I'm going to say 17. We're going to guess and hope for the best. 17 out of 10,000 to 32 out of 10,000 when you're 42 weeks. So since it doubles, we really want you to go into labor now before we get to that place. Okay, it doubles, but what are the numbers? Oh, it's 32 out of 10,000. 32 out of 10,000 is still very low. And maybe you're not okay with those risks, but maybe you are. And that's your decision to make, not the provider's decision. So then you can decide based on the numbers, not based on it doubles. That's so scary, right? But we want to know the actual data. The next tool would be to bring mom back into the conversation. So sometimes people can start to just speak around you and they're having conversations about you. We want to bring you into the decision-making process as the mom who's giving birth. And so partner can say things like, she can answer that. Let's ask her. What do you think, right? And giving her the opportunity to be part of the decision-making process. Another tool or strategy would be to bring the doctor into the room, or the midwife, right? So whoever's your provider. Sometimes what happens in a busy hospital setting is that the nurse is the one who is providing the recommendations from the provider from a game of telephone. So mom is in labor for a while, and then the nurse calls the doctor and updates the doctor, and then the doctor says, oh yeah, it's reached this amount of time to put her on Pitocin. Okay, cool. Nurse goes into the room and says, hey dear, so the doctor says she wants to put you on Pitocin. We get started like with this amount. We'll just increase it over time. I'm gonna need to give you the IV now. And the mom's like, wait a second, I don't want Pitocin. What are the risks and benefits? Like, and the nurse might kind of give an example or like share a little bit. And it's like, I still really don't want that. No, thank you. Okay. And the nurse goes back and calls the doctor and is like, she said no. And the doctor's like, she can't say no. She needs Pitocin. Try again. Okay. And we go back and the doctor says, you really need to get Pitocin. We're going to just stop this right here. If we're going back and forth, playing medical decisions, it's going to make your experience much more challenging. And you're going to be having all these conversations that are unnecessary. So if you start noticing that this is happening, I would say to the nurse, it seems like we're having a hard time like having this conversation, or it seems like we're playing a game of telephone. Could you bring the doctor in so we can have a conversation with the doctor about it? Thanks so much for taking care of us, right? So we're just gonna bring the doctor into the room and have the conversation with the doctor instead of going back and forth between the nurse and the doctor and the doctor and the nurse. The next strategy is called protect her when she becomes quiet, or protect them when they become quiet. So we wanna know beforehand, like I mentioned before, when you get overwhelmed and how. So do you freeze? Do you fawn? Do you become silent? Do you automatically agree? Do you nod because you want the conversation to end? What are the patterns when you don't feel safe or comfortable in a situation with a care provider? If then you notice as the partner or support person that mom is doing one of these things, right? They're just like nodding their head or just like agreeing, yep. And it seems like they're throwing their preferences out the window, and you know that this is something maybe they can do because they just want to feel safe in their nervous system. You can catch that and go, oh, she hasn't made a decision yet, or they need a minute. Let's give them a minute. Or could you clear the room for a little bit? Like give us some space and let us think about it. We'll let you know, right? So we're catching that, and we're going to make sure that mom isn't making choices as much as we can. I mean, you can't control what the mom does, but we can help protect the mom with our awareness around what their patterns are. If we notice those things, we can go, oh, maybe this isn't the best time to make a decision. Let's just like take a minute and think about it. If the mom's like, okay, yeah, I guess we could do that, like, how about we just take a minute and think about it? Is this an emergency? Do we have time to talk about it? We have time to talk about it. We have time to think about it. Okay, great. Well, we're going to take that time and we'll let you know in like 5 to 10. We're just going to go through a few contractions and just like check in. And yeah. Okay. So next would be the broken record. So this is a strategy that you can use if someone is saying that they want you to do something and you don't want to do that thing. And this strategy I illustrated a little bit earlier in the advocacy ladder when we were going over those like 7 steps. So this is kind of part of that. Basically, if someone says, okay, doctor's coming in soon, time to get on your back for delivery, you can say, no, she's staying in hands and knees. And if the doctor or the nurse says, oh, but you have to get on your back, then you can say, we said no. And then maybe the doctor comes in and says, why is she not on her back? And then you can say, yeah, we already talked to the nurse about it. We decided to decline her birthing on her back. Oh, well, how am I going to deliver the baby if she's not on her back? I understand it makes you uncomfortable, but the answer is no, we're staying in this position, right? So we're just going to keep saying no. Be prepared to say no again. There are people who are hospital staff that practice in a way that is very much like, we're just gonna do what we're gonna do, right? And so if someone says no, it's kind of like, oh, but you have to do that. Like, this is how we do things around here. It's normal if you're so used to doing things by routine for so many people all day long, every day for years. If someone is like, oh, we're not doing that, it's like, but you have to. Like, what? Like mind blow. So especially if they just don't really practice informed consent or more individualized care in that model or that culture at that hospital. So just be prepared to say no again. And that's okay if we don't want to be on the back and they say, but you have to. And you're like, oh, I guess we have to, it can feel like kind of scary. Like I said no, and then they didn't honor my no. They didn't respect my no. And then that can feel jarring to the nervous system. So be prepared mentally and emotionally to just say no again. Next, let's talk about some scenarios with the rest of our time that you can be aware of with specific interventions and conversations that you can have. So scenario 1 is using Pitocin to speed up labor. Use brain. What are the benefits, risks, alternatives? What does my intuition have to say? And what about doing nothing? Why is Pitocin being recommended? Is there a medical concern? What alternatives exist? Like what happens if we wait? Ask these questions, go through brain to help you make that choice, and then send everyone out of the room so you can make your own choice. The next scenario would be we need you on your back. So there are 3 specific tools that I recommend you try if you're wanting to decline being on your back. Maybe first I'll say the medical reason to be on your back is if you decide you want to use forceps or vacuum to deliver a baby, or episiotomy. These are very unlikely tools and should only be used in a medical emergency, but you do need to be on your back for those to happen. Or if the head comes out, but it's kind of like a really tight fit and the baby doesn't turn. If the head comes out and the head turns, that means the baby is in a good position and the shoulders aren't stuck, right? If the head comes out and then they turn like this. But if the head comes like to here and it's like a really tight fit and there's no rotation of the head, that could mean that maybe the shoulders are stuck. If the baby's shoulders are stuck, McRoberts is a position where they put you on your back flat, bring your legs back, and then try to deliver the baby by going in with a finger to get the arm that's stuck on the pubic bone and to bring the arm out like this to deliver the arm and kind of collapse the shoulder. Otherwise, there is not a medical reason to be on your back that I can think of outside of these very rare situations. So option 1 is to be vulnerable. Just explain why this matters to her. So she's coping so much better in an upright position. She becomes so much more uncomfortable on her back. Help them understand the person behind the preference. And also I would say it would just mean so much to us if you could support this. This is something that really means a lot to her. I understand maybe other moms don't mind as much, but this is really important to her and it would mean a lot if you could support that. Thanks for taking care of us, right? So we're being vulnerable. Option 2 would be to decline again. So she doesn't have to justify herself. We're going to go back to that broken record tool and just say, she already said no. The answer is no. We don't have to explain it. We're just going to say no. She's declining, right? Decline again. Option 3 would be to state the care requirement. So you could just say, this is the kind of care she requires. This is the kind of care we require. So this is a good one to use if providers or nurses are explaining that it is more inconvenient for them for the mom to be on their back. You can also use this in scenarios where with monitoring, we don't want you to keep moving with continuous monitors because the monitors move off your belly. We have to keep coming in and fixing it. Can you just hold still? Can you just stay on your side? Can you stay on your back? No, I'm going to keep moving. That makes our job so much harder though. I understand that it makes your job harder. And I really appreciate you, being willing to take care of me. This is the kind of care I require. Thanks so much. I understand it makes your job harder, and this is the kind of care I require. I understand that it's inconvenient for you, and this is the kind of care that we require. Thanks so much for understanding. Thanks so much for respecting our choice. It really means a lot, right? We are open-hearted. We are vulnerable and compassionate, but we are also firm, right? And what it is that we want. I feel like it's the way that I parent my toddlers. I'm just like, oh, we don't do that. We don't hit mommy. We don't eat toothpaste. That's the way it is, just like, oh, we don't do that. So I'm being loving and compassionate and also firm in what it is that I want. The last tool I want to give you is I understand and. So you can use this in these scenarios where birthing on the back or trouble with the monitors or someone's giving you some pushback around something. You can say, I understand, and this is what we're choosing. So they might say, but hospital policy says you have to get the hep lock in your hand when you get here, or you need continuous fluids or whatever it is. You can't decline that. I understand, and this is still my choice. I understand, and I'm not changing my mind. I understand that's the policy. I understand that's the way that you guys do things around here. I totally hear you. And I'm still going to make this decision. And our answer is not changing. right? Thank you so much for being part of our training today. For those of you who don't know, I have a free Peaceful Birth Academy with a free birth course, and it goes over my Peaceful Birth Method, which is a 5-step process to support moms in feeling confident and prepared for birth. So you can click the link in my bio if you're on Instagram. Below is a link to schedule a free birth breakthrough session with me, and this is a free one-on-one call where I'll give you clarity on the steps needed for you to feel confident and prepared for birth and explore if my coaching program would be a good fit for you. Okay, everyone, thank you so much. Have a good day. Bye.